Hello everyone. Today we'll be discussing about stroke localization. That too, specifically first we'll be discussing about cortical stroke localization. That is any stroke that has to do with the actual cortex affecting the frontal, parietal, temporal, occipital lobe. And then in the next video, we'll be discussing about brainstem strokes. So to understand any stroke, first one must understand the blood supply of the brain. Now, this is extremely high yield, and it's better if you draw it and practice it out a few times. So we'll start with our two vertebral arteries, which in the midline meet to form the basilar artery. Then here, for anterior circulation, we have the internal carotid artery, which gives off medial cerebral artery, which does not participate in the circle of Willis. There is the anterior cerebral artery. Now, the basilar artery, which we just discussed, continues as the posterior cerebral artery. Now, between the internal carotid artery and the posterior cerebral artery, there is the posterior communicating artery. And between the two anterior cerebral artery, there is the anterior communicating artery. So if I had to label it, this would be the internal carotid artery, ICA. This would be the MCA. This would be the PCA. And this would be the anterior cerebral artery. This is the anterior communicating artery. And this here is the posterior communicating artery. And there are a few other arteries that I think one must know. Is from MCA, we get something called the lenticulostriate arteries. This we'll discuss again in detail when we're talking about something called lacunar strokes. That will come way later on. But just remember, this is lenticulostriate arteries. And from the PCA, we get something called as thalamoperforator arteries, which I think that also you must know. Because if the lenticulostriate artery is involved, like just the lenticulostriate artery, you'll have pure motor strokes. And if there is thalamoperforator artery involved, you'll have a pure sensory stroke. This, of course, is the basilar artery. The basilar artery and the vertebral artery themselves give out very important arteries, but we won't be discussing it now. We'll discuss it in the next video when we're discussing about the brainstem strokes. This is the vertebral artery. Now, this is the circle of Willis. Here is an atlas image. So I'll just label it again. This would be the internal carotid artery. This is the middle cerebral artery. Then this is the posterior cerebral artery, the anterior cerebral artery, and this is the anterior communicating artery. This is the basilar artery. This is the vertebral artery. And this here, a small artery arising from the posterior cerebral artery, is the thalamoperforator artery. And these ones from the MCA are the lenticulostriate artery. Now, for the time being, it's just enough if you know these artery. Of course, I can go ahead and name these artery. This would be the superior cerebellar artery. This would be the anterior inferior cerebellar artery. You'll have the posterior inferior cerebellar artery coming directly from the vertebral artery. These would be the pontine branches, but you don't need to know that right now. So now that we know what forms the circle of Willis, now we should understand what do these actually supply. So this is a diagram showing three surfaces of the brain. So this is the superior lateral surface. this is the medial surface, and this is the inferior surface. It is very important that you know exactly which part of the brain is supplied by what artery. Now, the way I remember it, it's a very stupid way, but it somehow works. I just remember SMMA. That is, the superior lateral surface is mainly supplied by the MCA, and the medial surface is mainly supplied by the ACA. So if you see here, this is the superior lateral surface where the majority of the area is supplied by the MCA. And in the medial part of the brain, it is mainly supplied by the ACA. And the inferior surface will be supplied by the other artery, which is the PCA. So this is really important, especially in this area. If I take here would be the frontal lobe, here would be the parietal lobe. If I ask you what supplies the parietal or the frontal lobe, the medial aspect would be supplied by the ACA, whereas the superior lateral surface would be supplied by the MCA. And this is really important when it comes to stroke localization. Now, one more thing which I want to tell is I was telling there are few deep arteries, like from the middle cerebral artery, you have something called the lenticular striate arteries. Now, lenticular striate artery would supply the internal capsule, and you also need to remember thalamoperforator arteries and also thalamo-genticulate artery. As the name suggests, they're supplying the thalamus, which is the main sensory relay of the brain. So any lesion in these two arteries will have a sensory component, like a pure sensory stroke, and that comes from the posterior cerebral artery. Now, this is the coronal section of the brain showing what area is supplied by what. As we already said, the medial aspect here is supplied by the anterior cerebral artery. The superior lateral surface is by the MCA, which has two divisions, superior and the inferior division, which we'll discuss in detail later. And the MCA deep branches is supplying the internal capsule. And we know what this deep branch is. This is the lenticular striate artery. And then we have the posterior cerebral artery, and the posterior cerebral artery deep branches is supplying the thalamus, and that is the thalamoperforator artery. Now, you have to have this memorized. And if we look at a transverse section, the same thing. The medial aspect is by the ACA, the lateral aspect is by the MCA, and the deep branches again, which is the lenticular striate artery, will be supplying the internal capsule. And here in the posterior part, the occipital lobe is supplied by the PCA, and its deep branches here will be supplying the thalamus, and that would be the thalamoperforator arteries. Okay, now this is where the stroke localization actually begins. You need to know what is the sensory and the motor homunculus, because if you know this and you know where the lesion is, you'll know exactly what part of the body is affected. Now, if you look at the sensory homunculus, this side is the sensory homunculus and this side is the motor homunculus, and they are pretty much the same. They're almost the same. So here, in the medial aspect, we know this is supplied by none other than the ACA, which is the anterior cerebral artery. And what is it supplying? When we talk about the somatosensory cortex, the sensory homunculus, it is supplying predominantly the lower limb. And even the same when it comes to the motor homunculus. So by this knowledge, if a patient has an anterior cerebral artery stroke, he'll have loss of sensation from the lower limb may predominant, and also weakness in lower limb predominant. And obviously, from basic neuroanatomy, we know that the fibers always cross over. So if there's a right ACA defect, you'll have a contralateral lesion on the left side. Now, coming to this area, the lateral surface, we know the lateral surface is supplied by the MCA, the middle cerebral artery. Now, in middle cerebral artery, the main things that you should remember is the upper limb and also the face. So if a patient has an MCA stroke, the lesion would be loss of sensation from the face and upper limb, and also weakness in the facial muscles and upper limb muscles. And of course, it will be on the contralateral side. Okay, this was about MCA and ACA. Now, PCA supplies mainly the occipital lobe, which has the visual cortex. So if any PCA stroke predominantly usually presents with a visual field defect. What type of visual field defect we'll discuss later. But now that we know this, we can go ahead and oversimplify things. This is not always true, but if this is a stick figure, we can draw him like this. Let's imagine this is his legs, so it will make an A. These are his upper limbs, and he also has a mustache. And finally, he's wearing sunglasses. So what do these things mean? So A obviously stands for anterior cerebral artery, in which the symptoms would be predominantly in the lower limb than the upper limb. Here M stands for MCA, where there'll be a predominance of upper limb and face more than the lower limb. And P stands for PCA, which will present with visual field defect. But it's not just enough if you say the lesion is in the posterior cerebral artery, MC or AC. You need to be a bit more specific. Now, I want to take a detour and discuss something called aphasia, which can also be called as dysphasia. Now, aphasia is a disorder of speech and language where a person cannot really communicate well, if I had to simplify it. Now, when it comes to speech, there are a few important areas in the brain, which I'll illustrate. The famous Broca's area, which is the motor speech area. Then we have Wernicke's area, which is the sensory speech area. And between these two, there's always a connection, obviously. First, you need to have a sensory input, which you should process and send it to the motor area. So after that, you can produce actual speech. So there needs to be coordination between the motor area and the sensory area. And the connection between Broca's and Wernicke's area is called the arcuate fasciculus. Now, of course, speech is not that simple. Now, how do we get the sensory input? Now, sensory input can be both auditory or visual. So to say in case of auditory stimulus, here would be the primary auditory area. And here would be the primary visual area. The primary auditory area sends its inputs to Wernicke's area. The primary visual area, through something known as the angular gyrus, or gyrus, however you want to say it, sends inputs to Wernicke's area. So from Wernicke's area, it goes to the Broca's area through arcuate fasciculus. Now from Broca's area, it would obviously go to the primary motor area. From then, there'll be inputs to the muscles of the the vocal cords, then you can obviously speak properly. So this will be the primary motor cortex. So again, you either hear something or you read something. Whatever it is, it will go to the sensory speech area, which is the vernix area. Then from vernix area, it will go the Broca's area through the arcuate fasciculus, and from Broca's area, it will go to the primary motor cortex, and after which you can produce speech. Now, whenever you discuss aphasia, you discuss it under predominantly three headings. That is comprehension, fluency, and repetition. Now, I can make things really simple. So, for repetition of speech, you only need three things. One is the Broca's area. One is the vernix area, and then the arcuate fasciculus. So, if there is lesion to any one of these, the patient cannot repeat what you say. There'll be loss of repetition. If you just know this, you can basically figure out the rest. So let's discuss types of aphasia. First, we'll discuss something called as Broca's aphasia, which is also known as expressive aphasia. Okay, now where's the site of lesion? It is Broca's area. Now, what if I want to be more specific? Now, okay, you can say that the site of lesion is in the Broca's area, but what about the arterial lesion? This would be superior division of MCA. All right, if we go back, the Broca's area is actually situated in the frontal lobe, and the vernix area is situated in the temporal lobe. But whatever it is, both of these derive their blood supply from the MCA. Now, the Broca's area is situated higher up, so the MCA gives up two divisions, one in superior division and one inferior division. The superior division supplies Broca's area, MCA, and then you have the inferior division. And one more thing that I want to say is it is the dominant cortex which is responsible for speech. Just keep this in the back of your mind. This will come in handy later. So now, Broca's aphasia or expressive aphasia is a lesion in the Broca's area or in the superior division of MCA. Now, let's see what will happen to comprehension, fluency, or repetition. I said there won't be repetition. If there is a lesion to Broca's area, arcuate fasciculus, or the vernix area, there won't be repetition. So let's mark that first. Now, what about fluency? Would there be fluency? No, there won't be fluency because your motor area is not functioning, so it cannot send impulses or send proper impulses to the primary motor area, and you can't bring about coherent speech. So there won't be fluency, but there will be comprehension because your sensory speech area, which is the vernix area, is fine. So you're receiving both auditory as well as visual inputs. Next, then we have vernix aphasia, just called as receptive aphasia. Again, the lesion will be in vernix area, or as I said, if you want to be specific, it's the inferior division of MCA. Now, once again, there won't be repetition. What about fluency? The patient will produce sounds which do sound fluent, but it just won't correlate with the question. Now, I can ask the patient, I'll ask, okay, what did you have for breakfast today? The patient's Broca's area is fine. He can bring about speech, but he's just not understanding the question. If you ask what the patient had for breakfast, he might say that I work as a policeman. So a way to remember is people sometimes remember it by word salad, but I think it's better if you know the logic behind it. Then the Broca's area is gone, Wernicke's area is gone. Then what about the next thing? It is the connection between the Broca's area and the Wernicke's area, which is the arcuate fasciculus. Now this is known as conduction aphasia. I said there won't be repetition because Broca's, Wernicke's, and arcuate fasciculus lesions, there'll be loss of repetition. I keep on repeating this, but this is very important to understand this. The unique thing is the patient will have normal comprehension and fluency, but the patient just cannot repeat the phrases. Next. Now, from the Broca's area, the fibers go to the primary motor area. So what if there is a lesion in the motor fibers from Broca's area? Fibers from Broca's area. So, you can see this in ACA strokes. Now this would be called as transcortical motor aphasia. Transcortical motor aphasia. Now, the peculiar thing is, this would present very similar to Broca's aphasia, where there will be comprehension, there won't be fluency, but there will be repetition. I said for loss of repetition, there needs to be a lesion within the Broca's, Wernicke's, or the arcuate fasciculus. Here, all three of them are spared, so repetition isn't done. Now, what if it's the lesion to fibers to the Wernicke's area? That you can see in a PCA stroke. Now, this would be called transcortical sensory aphasia. Again, it would present very similar to Wernicke's area, where there is fluency, there is no comprehension, but there will be repetition. So just make a note of this. This is the differentiating feature. Transcortical motor and transcortical sensory, they mimic Broca's and Wernicke's, but there will be repetition. Now, moving on. There are more. Now, what if there is a lesion to both the fibers to the Wernicke's area and fibers from the Broca's area? So that is, in that case, there'll be isolation of language centers. Now, this is something which you can see in ACA, MCA, PCA, watershed infarct. We'll discuss this in detail later. So this is called mixed transcortical aphasia. Okay, so here there won't be any comprehension because the fibers are not the impulse towards the Wernicke's area is lost. So there won't be comprehension and there won't be fluency because the impulse from the Broca's area is also lost. But there'll be repetition because again, Broca's, Wernicke's, and arcuate fasciculus are spared. Now there's another aphasia called global aphasia, in which both Wernicke's area as well as Broca's area are damaged, and biologic that would happen when there is a lesion in the MCA trunk. If See, if there's a superior division infarct, there'll be Broca's aphasia. If there's an inferior division infarct, there'll be Wernicke's aphasia. But if there's a lesion in the trunk, both the blood supply to Broca's area as well as Wernicke's area is gone. So in global aphasia, there is a lesion in the MCA main trunk. So what? There won't be comprehension, there won't be fluency, and then won't be repetition. And global aphasia also includes a lesion to the arcuate fascicula. So all three of them are damaged. Then moving on. Now these were the main aphasias, but now we also have few special aphasias. There is something called anomic aphasia. And I'd suggest you not to go in too much detail for this. Anomic aphasia. Now here the lesion is in something called as the dominant angular gyrus. Here, the peculiar thing is there'll be comprehension, there'll be fluency, and there'll also be repetition. Then what exactly is wrong? In anomic aphasia, the person is just losing words. So, for example, the person just won't be able to identify one thing. If you give him a pencil, he'll describe what that is. He'll be like, oh, you use this to write, you use this to draw, blah blah blah. But he just cannot name the object. He cannot tell that it's a pencil. So I think so there's a difficulty in naming. And if you remember this much, I think it's more than enough. Then next we have something called pure word deafness. Here the lesion is in the primary auditory cortex. Or if there is disconnection from Wernicke's area. So now if the primary auditory cortex is damaged, there'll be no auditory input. So the patient cannot comprehend spoken words, but since his visual area is intact, he can comprehend written sentences. And obviously fluency and repetition will be normal. Then there is something called as alexia, which we'll also discuss later. It's alexia. Alexia has a very specific lesion. It's in the splenium of corpus callosum, which is seen in a PCA stroke. Here, it's the exact opposite. The patient cannot comprehend written sentences, but his comprehension of spoken sentences is absolutely fine, and fluency and repetition are fine. Now, out of this, it's unlikely that they'll test you about anomic aphasia, pure word deafness, and alexia, but the rest of the things you must know, especially the main ones like Broca's aphasia, Wernicke's aphasia, conduction aphasia, and global aphasia. This is something which you have to know. Now, this was the major chunk of the discussion. Now, from now on, we'll be discussing like few isolated topics. There is something called Gerstmann Syndrome, or Gerstmann, however you want to say it. Here there's a lesion of angular gyrus. Lesion of angular gyrus of the dominant parietal cortex. Now, every single word in the sentence is very important. So there's a lesion of the angular gyrus in the dominant parietal lobe. And this, how do you figure out which is the dominant parietal lobe? based on from the question stem. If the patient is right-handed, it is highly likely that the patient's dominant cortex is the left side. It's the opposite side. In a left-handed patient, the dominant cortex would be the right side. In a right-handed patient, the dominant cortex would be the left side. And actually, statistically, in general, the dominant parietal lobe is the left lobe in 90 to 95% of the population. Now, the way I remember the symptoms is the dominant parietal cortex, or the dominant of anything, is involved in higher mental functions. So here you'll have very specific higher mental defects. Like there's a classic tetrad of Gerstmann syndrome. First, you'll have agraphia. Agraphia is the inability to write sentences. Then you'll have acalculia, is the inability to perform simple arithmetic calculations. Emphasis on simple. You can't just give them a complicated physics problem and expect them to solve it. Then you'll have something called finger agnosia, in which the patient cannot identify his or her own fingers. If you ask the patient, can you please lift your right middle finger, the patient will just be confused. And then there'll be left-right disorientation. In this, say if the patient won't be able to coordinate between the left and the right side. So if you ask the patient, take your right index finger and touch your left earlobe, the patient will just not be able to do it. And one more thing, the dominant parietal lobe, which is the left lobe, is supplied from left MCA. So again, this is also very important. And that too, if I have to add further, it's specifically the inferior division. Now, this is the classic tetrad, but of course, there are other symptoms. There can be aphasias. Aphasias are also, we learned anomic aphasia that could also be present. Then there can be apraxia. Apraxia is inability to perform a known motor skill, even though the patient has the patient is willing to do it, but he's just unable to do it. Now, why am I saying the patient is willing to do it? Because further on, we'll discuss something called abulia, in which just a person just doesn't have the motivation to perform an action. Then there can be visual field defects. What visual field defects? That we'll discuss later. So this was about Gerstmann syndrome. So if the question mentions about agraphia, acalculia, finger agnosia, left-right disorientation, it's a very easy diagnosis. Next is something similar. It's Hemispatial Neglect Syndrome, a very interesting syndrome. Here, the lesion is to the non-dominant parietal lobe. Again, non-dominant is emphasis on the non-dominant part. Now, what are the symptoms? They'll be contralateral inattention. The way I remember again, I said the dominant parietal lobe is responsible for higher mental function. The non-dominant is just about your awareness of your surroundings. So there'll be contralateral inattention. There'll be personal neglect. Now, what do I mean by both of these? Contralateral inattention means, let's assume you walk into a room, 4 people are sitting in front of you, and in front of the patient. If the patient has the non-dominant parietal lobe lesion, which is likely to be the right side, he'll ignore the patient in the left side. So if out of these 4 people, assume 2 people are sitting towards his right and 2 people are sitting towards his left, he just cannot focus on the people sitting towards his left. He'll just ignore them. So this is an example of sensory inattention. And in personal neglect, which is really interesting, is that the patient will be ignoring the one half of his body. So the patient might only shave one half of his face. If it's a woman, she might apply makeup only on one side of her face. And if the patient is, let's say, eating, he'd only eat from one half of the plate. If the patient is drawing, he'd only draw one half of whatever he's intending to draw. And if you give a patient to read a book, then in a line, he starts reading from the middle of the line. He just is ignoring one half of the page. Then other than this, few more interesting symptoms is there'll be asomatognosia. Asomatognosia is like inability to understand ownership. The patient thinks that his left lower limb just doesn't belong to him. He thinks it belongs to someone else. He doesn't know that he owns it. So that is asomatognosia. Then there'll be anosognosia. All these sound like tongue twisters. Anosognosia is there'll be profound. The patient just cannot understand the deficit he's having. He's just neglecting the problem he's having. So he very obviously has a defect, but the patient will just say that he's fine. Then there is extinction. There'll be neglect towards sensations also. If a patient has hemispatial neglect syndrome and let's say you touch both of his shoulders, the patient is only able to appreciate sensation on one of his shoulder. Now, if you know a bit about visual field defects, since the patient is ignoring one half of his field, how is it different from something called as homonymous hemianopia? In homonymous hemianopia, there is again lesion to one half of the visual field defect. Isn't that basically the same thing? The answer is no. Because if the patient has homonymous hemianopia, he always could just turn his head and then understand or perceive objects. But in case of hemispatial neglect syndrome, the patient just doesn't. Even though his visual field is fine, he's still ignoring them. He just doesn't turn. He cannot perceive it. So this is a very important distinction that hemispatial neglect syndrome and homonymous hemianopia are not the same. And just to add, statistically, this would be seen in right MCA infarction. So now I've brought some few pics. In first pic, we can see the patient has eaten his dinner from one half of the plate. Now in second image, this is showing the phenomena of asomatognosia, where a normal person can perceive his leg, but a patient with hemispatial neglect syndrome just doesn't think it's there. Then here is an exaggerated picture where the person has shaved only one half of his face. And these are a few important tests. This, you tell the patient to draw this, but you can see the patient has drawn only half of the clock, half of the face, and half of the flower, half the face also. So a few important tests. This test number 1 is called line bisection test. Here you give like a line to the patient on a piece of paper, and you ask the patient to draw a straight line through the center. Now what is happening is the patient is just ignoring one half of this, and he's only seeing this much. So he bisects the line here because he thinks the line is only this long. He's just ignoring the other half. Then second is cancellation test, where you give multiple lines and tell the person to cancel each of the line. And again, he has done only to half the lines, that too on one side. Then the most famous is the clock drawing test, where the patient draws numbers only on one half. Here, on this side, there are no numbers. So these are a few tests which you should know. Okay. Now, coming to the main part. I keep saying main part, but everything is the main part. Now let's discuss the visual field defects in PCA show. PCA supplies the occipital lobe, so there'll be a lesion to the primary visual area. But let's not get ahead of ourselves. Let's just draw the normal visual pathway. This is your eye, the left one, the right one. This is the optic chiasm. This is the primary visual area. Now, I'm assuming everyone knows basics of ophthalmology. So we'll only discuss about left side. So from left side, this is the temporal fibers of the left eye, which does not cross over, stays on the same side. First, it's the optic nerve. Then it's the optic chiasm. And after that is the optic tract. And then it forms the optic radiation, which I'm not drawing right now. And it relays in the primary visual cortex. Then, the nasal fibers from the contralateral eye comes and crosses over, and it travels along with the temporal fibers of our eye. So, in posterior cerebral artery stroke, there will be a lesion in the visual area number 7. So the lesion would be here. So just for simplicity, let's assume there's a left-sided PCA stroke. What is affected? Here, it would be ipsilateral temporal fibers plus contralateral nasal fibers. Just again, from one eye, I'm not drawing the other eye, the other fibers. For example, in the same eye, you'll have nasal fibers which have crossed over to the other side. In the other eye, the temporal fibers stays in the same side. But we're not concerned with that. We are only concerned with one side. So in this side, we have, in any side, visual cortex, we'll have the ipsilateral, as from the same side, temporal fibers, and contralateral nasal fibers. So that is the lesion. Now, in ophthal, whatever is the fiber, it carries the opposite field. What I mean is, temporal fibers are responsible for nasal visual field. Nasal fibers are responsible for temporal visual field. And similarly, inferior fibers will be responsible for the superior visual field, and superior fibers will be responsible for the inferior visual field. This is very important when we talk about MCA stroke visual defect, because there things get a bit complicated. So temporal fibers will be carrying nasal visual field, and nasal fibers will be carrying temporal visual field. So if I have to draw, if this is the eye, this is the left side, this is the right side, not really the defect. You have ipsilateral. In this case, ipsilateral is the left side because we are assuming that the stroke is on the left side. So you'll have ipsilateral temporal fiber lesion. So you'll have ipsilateral nasal visual field loss, which should be here. Then on the contralateral side, you have contralateral nasal fiber lesion. So you'll have contralateral temporal visual field, which should be this one. Nasal field is towards the midline, and temporal visual field is towards the towards the lateral side. But there is one really important thing is that in both of these cases, there'll be a phenomenon called macular sparing, because macular in the occipital lobe, there's an area called the macular area, which is responsible for central vision. That is actually supplied by the middle cerebral artery. The way to remember it is M for middle cerebral artery, M for macular area. So macular visual field is due to middle cerebral artery, and this is extremely high. If I have to name this, I would call this contralateral. Why contralateral? Because when you compare it to the side of the lesion, the visual defect is on the other side. So if the lesion here is on the left side, but the visual field defect is towards the right side, the opposite side. So hence, that's why we call it contralateral, homonymous, because similar visual field defect in both, homonymous hemianopia, because half of the visual field is contralateral homonymous hemianopia with macular sparing. Now, the most important takeaway message is this: there is macular sparing in a PCA stroke, which is very important. If the patient has a bilateral occipital lobe lesion, other than blindness, there might be something called as Anton syndrome also, which is cortical blindness. But the patient is blind, but he's denying that he's blind. But that's for another day. So this was the visual field defect seen in a PCA stroke. Now moving on, the visual field defect in MCA stroke is interesting. Now we need to understand few things. This is the brain. This would be the frontal lobe. This would be the parietal lobe. This would be the occipital lobe. And this would be the temporal lobe. Now, we know that the optic pathway starts from the retina, optic nerve, optic chiasm, then you have the optic tract, and then you have something called optic radiation. Why is it called optic radiation? Because it literally radiates through the brain. So now, if I had to draw, if this is the optic, let's assume optic tract, which then becomes optic radiation, the fibers actually, some of it goes to the parietal lobe and some of it goes to the temporal lobe. Now, whatever goes to the parietal lobe is called Baum's loop, and whatever goes through the temporal lobe is called Mears loop. A way to remember it is temporal has an M, and Mears also has an M. Okay, now, before we talk about the defect, just like how there was a blood supply difference for Broca's aphasia and Wernicke's aphasia, similarly, you'll have the MCA, the superior optic radiation, superior optic radiation will be supplied by the superior division of MCA, and the Mears loop would be supplied by inferior division of MCA. Superior MCA, inferior MCA, MCA. Now, the most important thing, if I ask you, what is the Baum's loop carrying? Based on the previous knowledge in PCA stroke, the fibers will be the same almost. So you'll have ipsilateral temporal fibers. Now, since it is superior, the Baum's loop compared to Mears loop superior, it is carrying ipsilateral superotemporal fibers and contralateral superior nasal fibers. Mears loop is carrying ipsilateral temporal fibers and contralateral infero nasal fibers. So if you understand this, now the lesion can be here. For the sake of this discussion, I'll be using green, though normally for lesion we use red. The lesion can be here, that is due to superior middle cerebral artery, can be here between inferior middle cerebral artery and or it could be MCA. Now, let's discuss further. Now, again, assuming a defect, the lesion is on the left side. Let's assume there is a left superior division of MCA lesion. Can you please tell me, so that you keep repeating, what is lost? It is ipsilateral supero temporal fibers plus contralateral supero nasal fibers. I hope this is clear. So now, if we draw the visual fields, this is left, this is right. Again, in ophthalm, it's always the opposite. The superior fibers are responsible for inferior visual field, and the temporal fibers are responsible for nasal visual field. So based on this, you'll have ipsilateral loss of inferior nasal visual field, that is here. And contralateral superior is inferior visual field, and nasal is temporal visual field. So you'll have contralateral loss of inferior temporal visual field. Now, how would you name this? You'd name this contralateral homonymous inferior quadrant anopia. But this is famously called by something else. It's famously called pie on the floor sign. This is important. Now, we are not done here. Now, what about assuming the lesion is in the left? Again, we are always discussing, we'll always talk about left-sided lesion, just so that we don't get mixed up. Left inferior division of MCA lesion. And you tell me what is affected. You'll have ipsilateral inferotemporal fibers lost plus contralateral infero nasal fibers lost. So if I have to draw the visual field, this is left, this is right. So we'll have ipsilateral inferotemporal fibers, which by now you'd be knowing. So the visual field loss would be supero-nasal on the left, on the same time. Contralateral inferonasal fibers loss will produce a loss of supero-temporal visual field here. Now, I would call this contralateral homonymous superior quadrant anopia. or if you have guessed it, it's called pie in the sky. There's a very nice way to remember this. You just have to remember TIPS. What does TIP stand for? T stands for temporal lobe. I stands for inferior optic radiations. And PS stands for pie in the sky. So you'll have inferior division of MCA lesion would affect your temporal lobe, and you'll end up with pie in the sky. That would be contralateral homonymous superior quadranopia. Left-sided superior division of MCA lesion, then up with pie on the floor side, which is contralateral homonymous inferior quadranopia. This is really important. And one thing which I really want to tell, in MCA strokes, you won't have macular sparing. No macular sparing. Now that exactly brings to my next point. Now, I have a question. My question is, what if MCA trunk is affected with a lesion? Now, then there'll be entire optic radiation lesion, correct? So, that would be what? Ipsilateral temporal fibers plus contralateral mesial fibers. Now, this sounds oddly familiar. We saw a similar defect when we are talking about PCA stroke, wherein you'll have a contralateral, you'll have contralateral homonymous hemianopia. But what is different here? As I said, you'll have contralateral homonymous hemianopia. The difference here is there is no macular sparing. Now, if MCA stroke visual field you find difficult, most of the time they just ask about MCA trunk lesion, wherein you just have contralateral homonymous hemianopia with no macular sparing. So if you just remember, you should remember everything, but if it's difficult for you, if you just remember that in PCA stroke there is macular sparing, and in MCA stroke there is no macular sparing. Now, one more thing is you have to correlate, because superior division of MCA lesion will also present with Broca's aphasia. And inferior division of MCA lesion will present with Wernicke's aphasia. Sometimes it is a PCA stroke. They'll just tell that the patient has homonymous hemianopia, but they sometimes just don't say that the patient has macular sparing. So then you have to correlate with the rest of the history, because if it is an MCA lesion, not only will the patient have homonymous hemianopia, if it's the trunk, the patient will also have global aphasia. So that is the take home position. Now, there's something called gaze deviation. It's simple. If this is your eye, with the eye midline, there is an area called frontal eye field. So it's area number 8, and very important, it's supplied by MCA. middle cerebral artery. Now, the frontal eye field is responsible for your normal gaze. Normally, if you're looking straight ahead, you're looking straight. Your gaze is not shifted to right or left. So, what your frontal eye field does is it always tries shifting your eye towards the other side. So, now if you're only talking about the left eye, the same side, left frontal eye field, is trying to shift your gaze towards the right, towards the opposite side. But your right-sided frontal eye field is doing the same thing towards the opposite side. So normally both of these impulses are in harmony, and there is no obvious gaze shift unless you want it to occur. Now, assuming there is a defect, an MCA lesion here on the left side, the left frontal eye field can no longer push the eye towards the other side. So obviously, naturally, the other side impulse predominates and your gaze is shifted. So one thing you can notice is there was a left MCA lesion and your gaze ended up shifting to the left side itself. So in MCA stroke, there is gaze deviation to the side of lesion. This is the most important part. So now we have learned so many things about MCA stroke. In MCA stroke, the patient will have aphasia. Okay, let's assume the patient has left MCA. The patient could have Gerstmann Syndrome with the classic tetrad, which is acalculia, agraphia, finger agnosia, and left-right disorientation. The patient can have aphasia also. On top of that, the patient will have uh, right-sided visual field defects. If it's the trunk, assuming the patient will have contralateral homonymous hemianopia without macular sparing, and also since it's MCA, the patient will have loss of sensation and motor weakness in the contralateral face and upper limbs. And also the gaze will be shifted towards the same side. That would be to the left side because you went with the assumption that the lesion is on the left side. So you learn so many things about MCA strokes. Now there are other few things that I have to add, which I'll add towards the end of the summary. Okay, now few miscellaneous topics. ICA stroke. ICA, gives off, if you remember from the circle of Willis, ICA is the one which is actually giving off anterior cerebral artery and middle cerebral artery. So in the case of ICA stroke, you'll have features of ACA plus MCA stroke. Simple. But then you have to correlate it with the side of the lesion, like hemispatial neglect will be present in most of the people right-sided ICA stroke, whereas you can have Gerstmann syndrome if the patient has left-sided ICA stroke. There's one more sign called amaurosis fugax, whereas the patient has transient monoocular blindness. This is seen in transient ischemic attacks also. This is like one of the early signs of, say, carotid atherosclerosis. This is the classic warning sign. In this case, you can see something called, if you see here closely, you see this in this fundoscopy. This is called as Holland-Horst clock. This is just a cholesterol clock. This is it's a very important clinical sign, Holland-Horst clock. Next, what about lacuna stroke. This is where the lenticular-striate arteries, the thalamoperforator arteries, all of these things are. Lacuna stroke is nothing but a small vessel disease. The areas affected is like, let's assume it's just small arteries, the branches of the major artery, MCA, ACA, and PCA. So if there is a lesion in the lenticular striate artery, the patient will have a pure motor stroke with no other symptoms. Why pure motor stroke? Because lenticular striate artery supplies the posterior limb of the maternal capsule. It could be thalamoperforator artery. Thalamoperforator artery. In that time, the patient will have a pure sensory stroke. Then it could be area supplying the basal ganglia where can be many symptoms. Like, for example, let's assume the patient has lesion in the putamen, which is like, for example, seen in Wilson's disease, there'll be wing beating tremors. If the patient has lesion in the substantia nigra, the patient will have Parkinson's disease, where you'll have bradykinesia, shuffling gait, and all that. If the patient has lesion in the lentiform nuclei, the patient can have chorea and dystonia. And if it's the subthalamic nuclei, the patient will have like flinging movements and all that. Now, yeah, if the question mentions something like very particular, like a pure motor stroke, pure sensory stroke or something, and very important thing in question is there'll be no cortical signs. What are the cortical signs? All the special things which we discussed till now, like aphasia, acalculia, all that. There won't be cortical signs. And learning the pathophysiology behind it is quite important. This you see in like long-standing hypertension and also diabetes mellitus. This causes something called as lipohyalinosis of small vessels. Yeah, this is quite important to know actually, this term called lipohyalinosis. It's in long-standing hypertension and diabetes mellitus. This is more than enough what you need to know in lacuna stroke. Next, coming to a few final miscellaneous topics. There's something called watershed area, and watershed area is the area which lies between two major arterials and pylon. Now, here, for example, this is an area, this is an ACA MCA watershed area. We know here in the midline, this is supplied by ACA. This would be MCA. Now, the area between these is MCA. Why is this watershed area important? When would you see a lesion in the watershed area? Now, let's assume the patient has severe hypotension. The blood supply here is fine, but the distant areas or the watershed areas where both the small collaterals meet, this area would greatly suffer. And even here, this is the MCA territory, this is the PCA territory, and between that you have MCA PCA watershed area. And this is the transverse section, and I think it's good if you know the transverse section and approximately where the ACA, MCA, and MCA, PCA watershed area lies. So now what will be the symptoms? Now, let's assume there is ACA, MCA watershed stroke. It classically leads to something called man-in-a-barrel syndrome. Now, it's better if you understand it, but if you really want a way to remember it, you can remember man-in-a-barrel. It's between MCA, KCA, watershed area. Now, if you correlate with the sensory homunculus, what lies here is mainly the proximal upper limb. So the patient will present with proximal upper limb weakness and loss of sensation. Contralateral, of course. And this is called as, could be called as brachial light ratio. So why is it called man in a barrel syndrome? You can imagine a man, you can imagine a barrel through which down the patient has legs. The patient is like inside the barrel, but he has like two holes for his legs. But his arms, his upper limb is inside the barrel and only his head is popping up. So now, since his hands are inside the barrel, he can't really use it. It's something similar in man in a personum. His lower limb power, the sensation, everything is intact, but his proximal upper limb is weak. He cannot really use it. There's no point. And other than this, the patient can have uh, aphasia also, but this is what you need to know. Now, what about the MCA PCA watershed infarction? That is called Bálint Syndrome. Watershed infarction. Now, this has a very classic triad. First, you have something called oculomotor apraxia. I discussed that oculomotor apraxia, like apraxia means the patient doesn't have the ability to perform a previously known skill. So now if you do like his, the eye field testing, the patient wants to see the other side, but he just doesn't know how. He just doesn't know how to move his eye muscles. He doesn't know how to look right, how to look left. So that's all. He has the will to do it, but he just cannot do it. Then there is optic ataxia. This is very different from the normal ataxia. If the patient has normal ataxia and you do the finger nose test, the patient struggles to bring your finger towards the examiner. The patient is struggling to bring his finger towards the examiner's finger as well as his nose. But in optic ataxia, the patient is only struggling to bring his finger towards the patient's finger, but he can reach back to his nose without any difficulty. So that is optic ataxia. And then you have simultaneous agnosia. Simultaneous agnosia is, the way I can describe it is, it's the patient is seeing many things, but he just can't put it all together. He can only perceive one thing at a time. Now, classically, it's called, it's started as not seeing the forest for the trees. The patient can see individual trees, but not the entire forest. That is simultaneous agnosia. So this was a classic triad. And man in a barrel syndrome and Bálint syndrome are rarely tested, but I had to lose. Now, these ones, just a summary. We have all these special terminologies. Aphasia is disorder of language and speech, which we discussed it in detail. Alexia is inability to read. One high yield thing is, this also might be tested. There is alexia without agraphia, which is seen in PCA strokes. I think this is extremely high yield. Just for enough, should I say, where do you see alexia with agraphia? This I can actually see in Gerstmann Syndrome actually. Because In dominant angular gyrus, um, now the sensory cortex and the visual area and the visual association area relate to the angular gyrus first before it goes to the vernix area. It's seen in MCA stroke. What is agraphia? Agraphia is when the patient can't write. Acalcular is he can't do basic math. Finger agnosia, we discussed the patient can't recognize his own fingers. And left-right disorientation. If you remember, these three, agraphia, acalculia, finger agnosia, and left-right disorientation is the tetrad of Gerstmann syndrome. Then hemi-neglect, discuss it in detail. You need to know the clock drawing test. Anosognosia is profound lack of awareness. This can also be seen in hemi-neglect syndrome. Asomatognosia is the patient can't recognize his own body parts. Next, you have apraxia. Apraxia is the inability to execute previously learned activity, in which you have many types, but not that high. There are many types like ideomotor, ideational, oculomotor apraxia, which we discussed, was one of the triad of Bálint Syndrome, with stressing apraxia, gait apraxia, and all that. But yeah, amnesia is pathologic loss of memory, and it can be retrograde, anterograde, whatever. One high fact, where if they ask where do you see amnesia with confabulations, is Korsakoff psychosis. Amnesia, confabulation is the patient has lost memory, but the patient is like the brain is subconsciously making up false memories to compensate for the lost memory. This is also called white lie. The patient is technically not lying; it's his brain. Abulia is no will to initiate a movement. They'll be apathic. Dysphagnosia is quite sad actually. The patient can't recognize familiar faces. This is seen in the lesion to visual association area. So the patient can like describe the face in like excruciating detail, but he just can't identify. Even if this is a patient's wife of 50 years, he just can't recognize who that is, and that is very sad. Achromatopsia is colorblindness. Dysarthria is disorder of speech articulation, not to be confused with aphasia, because here the lesion is not within the language centers. Dysphagia is difficulty in swallowing. Ataxia is lack of coordination. This is a summary of all specific types of stroke. Now, ACA, which we didn't discuss like in a lot of detail, but this we did. There'll be lower limb predominant weakness and loss of sensation. At this point, I'm not talking about contralateral and ipsilateral because you should know at this point. Yeah, few other specific symptoms. There can be urinary incontinence. There'll be abulia. They said the patient just doesn't have the will, the interest to start a movement. Then important personality changes and primitive reflexes. The way I remember it is primitive reflexes are like one of the first reflexes which you get. So F for first reflexes and F for frontal lobe. So these are important: abulia, personality changes, and primitive reflexes. Then other than that, right MCA dominant hemisphere, we have facial face and upper limb predominant, gaze deviation to the same side, aphasia with no macular sparing, and we know we learned pie on the floor and pie in the sky sign, and we have Gerstmann syndrome, obviously. Then right MCA non-dominant hemisphere, we have mainly the hemispatial neglect syndrome. PCA, important things, there is macular sparing, there is alexia without agraphia, and one miscellaneous thing is there's something called thalamic pain syndrome, because PCA gives off branch which supply the thalamus. There can be a thalamus lesion, and when it's healing, when the thalamus is healing, like post-stroke, there is increased sensitivity to pain. So that leads to thalamic pain syndrome, which is also called as this. This is really hard to pronounce. Dejerine-Roussy syndrome. Okay, whatever. Then there can be midbrain involvement, which we'll discuss in the next video. ICA is Amaurosis-Fugax, Hollenhorst, Fox, and lacunar stroke, which is the most important. There are lack of cortical signs. There'll be pure motor or pure sensory strokes. And watershed area, there's Manila-Barrow syndrome, there is MCA and ACA watershed area, and Bálint syndrome with the classic triad. This is it. Let's quickly solve a few questions. Please remember that stroke might seem easy and you might know the concept, but the questions are still very annoying. You might know the answer, but you still might end up marking the wrong answer, and that is completely fine. Now, let's approach this. Patient has anxiety, depression, hypertension, diabetes. There is sensory deficit affecting her entire face, arm, trunk, and leg. So the entire one half of the body is affected. And there are no motor deficits on the exam. This is the main clincher. So it's a pure sensory stroke, which we know is seen in lacunar strokes, which is a small vessel disease. It's pretty easy. Next, a 52-year-old man with a history of smoking, diabetes, mellitus, and hypertension presents with acute onset of left hemiparesis affecting face, arm, like basically entire half of his body. He recognizes the left side of the body and acknowledges the deficit. So it's not an MCA, unlikely to be an MCA stroke. The gaze is not defeated, so it's definitely not an MCA stroke. Which of the following is most likely location of vascular occlusion? Once again, they have not mentioned anything about sensory loss. So if the patient has left hemispheres of face, arm, and leg, my first guess would be MCA stroke. But here, his gaze is not deviated, so it's not MCA stroke. And I would think it is a lacunar stroke where lenticular striate branches of right MCA are affected, as in a specific branch of right MCA that would supply the internal capsule. Next, you are asked to see a 42-year-old right-handed woman. So the dominant lobe is the left side. With diabetes and dilated cardiomyopathy, without acute confusion, on examination, she does not follow commands. So that means there is no comprehension. She's speaking fluently and says multiple phrases that do not make sense. This is pretty classic of Wernicke's aphasia. She seems to have visual field defect in the right hemifield. Very good. That means it's a left-sided stroke, but we already knew that because the patient is right-handed, so the dominant cortex is likely to be left side, and you get aphasia usually when the left when the dominant cortex is affected. So this is vernix aphasia, and vernix area is supplied by MCA, specifically the inferior division, and we know this is the left side, so the answer is D. A 59-year-old right-handed man again, dominant cortex will be the left lobe, present with neurological deficit. A brain CT scan is obtained and is shown in the figure, which of the following manifestation would not be seen in this patient with lesion. So if you see the scan, the lesion is here. This area appears to be darker than the rest. So this is the parietal lobe on the left side. You read CT scan from the foot end, so it's the opposite side. This is the left side and this is the right side. So let's eliminate the options. Left-sided, this is the occipital lobe. Sorry, I think I said parietal lobe, but this is the occipital lobe lesion. Left-sided occipital lobe, can it give rise to right homonymous hemianopia? Yes, it can. Can it give rise to anomia? Yes, if the visual association area is affected there, the patient can have anomia. Can it give rise to alexia? Of course. Again, visual association area, not that. Specifically, it's the splenium of corpus callosum, which is supplied by the PCA. Can it give rise to visual agnosia? Yes, if there is visual association area deficit. Can it give rise to expressive aphasia? No. Expressive aphasia is Broca's aphasia, which should see it in a superior division of MCA stroke. A right-handed patient presents with acute onset neurological deficit and an MRI of brain is obtained. So it's asking what would be the manifestation. This is the site of the lesion. This is left. This is the right. This to me seems like an MCA stroke. On the left side, there won't be neglect because that would be hemispatial neglect is seen in the non-dominant lobe, and in this case, it will be the right lobe. Gaze deviation towards the right, no. The site of lesion on the left side, and in MCA stroke, the gaze deviates to the side of the lesion. Global aphasia, yes, could be the paresis of the right leg more than the face. No, it would be predominant upper limb and face. Left homonymous hemianopia, no. Since it's a left-sided lesion, the visual field defect would be a right homonymous hemianopia. So the answer is global aphasia. Let's do this a bit quick. Right-handed man, history of atrial fibrillation and hypertension. He has right hemiplegia affecting face, arm, and leg. His gaze is deviated towards the left, and he seems to have right homonymous hemianopia. He is globally aphasic. What is the location of the vascular occlusion? Now, this is very simple. Since first, it's the right-sided homonymous hemianopia, so the lesion would be on the left side. Okay, all the options say left side, and the patient is globally aphasic, so that means it has to be the trunk of the MCA before the bifurcation. Now, if you're asking why there is like, whenever we discuss the strokes, we usually said upper limb predominant. When I say upper limb predominant, that doesn't necessarily mean that the patient won't have lower limb symptoms, but the upper limb predominance. So they could have lower limb symptoms as well. A 52-year-old woman with diabetes awakens with the right body weakness, and there is symmetric upper motor neuron pattern of weakness involving face, arm, and leg. Again, no sensory abnormalities. Language is preserved. A stroke associated, yeah, this is very simple. This is a lacunar stroke, and since it's a motor neuron lesion, it's a pure motor stroke, which would be seen in internal capsule stroke, which is supplied by the lenticular striate artery. So this is a lacunar stroke. Okay, so right-handed man, entire left half of the body. This is a loss of sensation. It's only loss of sensation. They're not explaining anything about the motor loss. So again, my answer would be a lacunar stroke, and since it's a sensory stroke, it would be thalamus. A 72-year-old retired school teacher has abrupt onset right face and hand weakness, disturbed speech production, right homonymous hemianopia. It's right-sided weakness, right visual field defect. So it will be a left vision, and speech production, I always think MCA. So it's simple, left middle cerebral artery lesion. A 75-year-old man is brought to the emergency department because of involuntary twitching movements of his right arm that started last night. He was writing when his arm flung the pen across his desk. Long-standing hypertension, diabetes, mellitus. He's not taking any medication as prescribed. Physical examination shows wild swinging repetitive motions. So, since the patient has hypertension and diabetes, I would think it is a lacunar stroke, and they have given wild swinging repetitive motions. This is a basal ganglia stroke, and this is a seen in subthalamic nucleus stroke. You just have to remember, internal capsule will produce a pure motor stroke, and the lentiform nucleus would present with chorea and dystonia. The putamen, there'll be wing beating tremors. Then substantia nigra will have features of Parkinson's disease. Okay. Which of the following is most likely the mechanism of stroke involved? The pattern is here. This is actually, if you correlate it with the previous discussion, this roughly coincides with the areas of the watershed area, MCA, PCA, and ACA. So this is actually due to hypotension, a setting of cardiac stimulus. I mean, by the elimination, cannot be embolic, lacunar, embolic, or venous infarction. It's because of hypertension. That is watershed infarction. A 59-year-old woman with history of atrial fibrillation and hypertension presents with the right hemiparesis, affecting mainly the face and arm. Her eyes are deviated to the left, so it's a left-sided lesion. She seems to be able to understand. There is comprehension, understand and follow commands. She cannot verbalize and appears frustrated when asked. This frustrated word is important. This is expressive aphasia or Broca's aphasia. In Broca's aphasia, the patient appears frustrated because they can understand the question, they want to try to answer, but they just can't answer. So they are frustrated, and it's a left-sided lesion because the gaze is deviated towards the left, and we know Broca's area is supplied by the superior division of the MCA. So my answer will be this, C. Yeah. So that was it with the cortical strokes. Please practice more questions. As you keep practicing it, the topic will stick better. And in the next video, we'll be discussing about brainstem strokes. Thank you.